Good morning, everyone. Thank you for joining me at another Back to Basics Practice Management topic and session today. We are going to be talking about EMR and EHR and how do we embark this journey in our independent private practices, and also just the planning stages for that, our decision making for these things, and also to recognize that each practice is different in size and scope. And so keep that in mind during our discussion that, what is relevant to your practice may not be relevant to others. So just keep that in mind. That said, I'm excited for our special guest today. Sherwin Gaddis is from Juggernaut Systems Express. He has been in the business of customizing electronic health records for the past 12 years. GSE has three brands that are tailored to primary care, behavioral health, dermatology, and wound care. GSE works with nationally and internationally clients. GSE strives to work closely with their clients to build the best in class EHR experience that meets the needs of the practice. In short, GSE builds dreams. So I'm looking forward to discussing with Sherwin all things about EMR. We have some really good questions and topics today. And again, I just want to stress and emphasize that what is good for your practice may not be the same for another practice. Your size and scope needs to be considered, whether you're a 3-man crew or a 20-man practices, or you have very different locations. So again, just keep those things in mind as we talk about the tips and things that we're going to go over about essentials that may be relevant to you in your practice, all things EMR and EHR. So without further ado, we're going to dive into this topic with Sherwin. Hi, Sherwin. How are
Hey,
you?
I'm doing fine, and you?
I'm doing well. Happy Monday. I think you're also in the East Coast, right? Like me. Where are you essentially from where I am? So I'm in Pennsylvania.
I'm in Virginia.
Okay, so East Coast, so that's good. We're in the same timeline. Um, so let's dive into our topic though, because we have a lot to cover.
Okay.
So I want to get started in terms of our questions, but before that, I want to ask you this one other question. What got you interested in EMR and EHR build? Like, what got you into this?
Wow, you're on point because I was thinking about that this morning, and it comes to mind from time to time. But it's a couple of people that were in my past that has the biggest influence on this whatsoever. And one of them being my grandmother. And, as our parents age and they have ailments, her dementia was one of the things that spurred me. Now, granted, I'm not a medical person, and I know I don't do well in the medical industry, but I do well in electronics and things of that nature. So therefore, I'm using the skills that I have to help the medical industry. Also, my stepfather, who was a psychologist, okay? And
Mm.
unfortunately, in my life, he played a really big role in, of course, my upbringing and growing up. But he was one of those Vietnam veterans,
Mm.
and unfortunately, because of what he came back with and all the things that he was dealing with, he ended up taking his life. But I did, while he was alive, help him with uh, his office and taking patients and bringing them to them and doing things around the office, being around that medical community. I've always wanted to help in some kind of way. And so, with my background in electronics and then learning the code, that's what got me involved in this particular part of the industry.
That's a very interesting story, and in a way that you have been immersed in healthcare industry, with not being somewhat of a clinician, if you say, but you've been exposed to the environment and surroundings of healthcare, in the way of, for some of us, I'm also not a clinician, but I'm a healthcare consultant that's been exposed to clinicians being in the practice and also taking care of our loved ones. I think those are things that put us into as part of being frontline in the way of how we become caregivers and advocates for our loved ones, hence which are also patients, in the medical community. So
Yeah.
that's fascinating how you've come into that. You've just married your electronics, or I guess engineering mind into and lending itself to the healthcare industry. So that's wonderful.
Yes.
So let's get into a scenario in our medical facility world, in our physician practice, and I want to focus us on the independent practices in the way that, if I'm a new physician practice engaging my new practice, and I happen to be either a behavioral health or dermatology, or maybe even primary, as what you have noted are areas that you have scope and eye on, and I'm ready to, I'm getting ready to open my practice. I've, gotten everything that I think administratively, and, as it relates to the business, because there's also operations in that right before I open my door. But now we want to talk about EMR and EHR. So that's one scenario. The second scenario is I'm an existing physician practice. I'm also not happy with what I have. And, we're either expanding or downsizing. And we're looking to switch, EMR, EHR, because we're not happy with what we currently have. So what would be, scenario A, best suited for its needs? So what are, like, the best practice and guidelines to consider for a brand new practice who wants to open shop, and then an existing practice that is not happy with what they have and want to transition. So we could take that scenario A and scenario B with that question.
Okay. And we get both types of clients. And I'm going to use our recent experience on both of these because there's a dermatology clinic that we're working at in Florida, as close as I can get. They're working in Florida. And of course, they just went through this whole thing. And they were coming out of a practice in California. And and there's two of them. So they moved together to Florida. And they wanted to open up a clinic there. Now, granted, yes, they did go out and they have a job in a regular clinic where they're currently employed, but they still had this idea of opening up their own private practice. And so they worked with us to build the best in class because they already had in their mind what they wanted their software to do. And those are the people that we really like and that we really work with because they've worked with all the other pieces of software out there. And they want a piece of this one, a piece of that one, a piece of this one, because each one has its strengths and weaknesses. And so for us, we've taken the strength of each one of those pieces of software that they wanted and combined it into one. So they had an all-in-one tool that they could use to run their practice with. And those are things that, that can make the customizing of the software best run for that practice. So they did take into account the workflow, even though they're only going to be an unmanned office kind of to begin with, because they work with one of our partners that's going to have who's going to run the office virtually for them. So they'll take the phone calls, they'll make the appointments, and then of course the doctor just has to show up on time and see the patient. So they're going to grow their practice while they are yet still employed somewhere else. I don't know if I'm answering your question or not, but if I drift too far off, please let me know.
So I heard workflow. So which I think let's get to the basics part. In any practice, we want to at least understand how we do business, right? How is the workflow in existence today? Or if we didn't, as a new practice, I think workflow is still going to be important of how you're going to check in the patient, have that journey of the patient, who does the rooming, who's, before the physician or the clinician's going to see the patient. And then from there, the patient checks out, has a follow-up appointment, yes or no, and then we go drop a charge so that for that visit, that all happens in that one day, right? So
yes,
the clinic time. So I heard workflow. So we at least got piece one of workflow, which I think is important to note that if you are a new physician, you actually have an idea of what would that be operationally. Like, again, talking about a journey of the patient. You can also visualize that as well if you want to, have some drawing of what that looks like. And then some things you can also jot down in ways of what you're what I call a standard operating procedure, where what that looks like in operationally your workflow in your practice. Conversely, I say the same thing with an existing practice. If you have one, that would be now the time, if you're going to transition, look at what you have and say, okay, assess that and say, what does it mean when I transition something? What are some of the roles that exist today that may or may not be there, or it could be replaced with something else? So I think workflow is for the betterment, and what I heard is that is a key component that one may or may not have. It doesn't have to be so sophisticated in that sense, but make it where it grows with you as you're scaling. And I think that's also important. Again, it doesn't have to be fancy Visio or anything like that, but it could definitely live in your standard operating procedure that you exist today.
And that workflow plays into the EHR in this way, because you need to know who's going to touch where, because the EHR is going to be your collection point of data, but not everybody's going to put all of the data in. You're going to have your front desk that puts in a piece of data. You're going to have your MA or your clinician that's going to put in some data, and then your provider who's going to actually see the patient, then they put in their final piece of data. Then you mentioned the last point, whereas you're going to drop a charge. Okay, so of course we're all doing this in order to be compensated for the work that's being done. And knowing who is touching which point, even though, yes, some offices want to train everybody to do everything, and that's okay, because yes, you want to be able to fill in somewhere else when people are not there. But overall, there needs to be someone who's responsible for a particular set of data, so that you know who to go to when that data is not there. Rather than, of course, we play like little children. Well, I didn't do it. Of course you didn't do it, because it's not there. But who was responsible for doing it? But if you have nobody assigned to that responsibility, then nobody's responsible for putting it there.
Got it. I keep going to go back to the step one. So we have workflows, determination of roles and responsibilities, and then who's going to be entering this particular data, and how data is, going to progress through, as the journey of the patient, and when at the time that provider sees the patient. So then let's get to some forms, like tools in the sense of forms, and some smart phrases or smart tools that could also lend itself into efficiency. And what are your thoughts about, departmentally? When I say departmentally, meaning all the staff in the clinic has, similar tools that they can utilize versus, an individualized user preference tooling. So again, this is just, we're building the blocks of what this EMR is going to look like as we're embarking, how to decide on what this looks like. So what about those? Like, when should that be, is that the beginning, in the middle of that conversation?
It should be at the beginning of the conversation. And I have these beginning conversations quite often. And that's one of the things, if somebody doesn't bring it up, I'm going to bring it up, because, of course, it is I'm going to say, second tool in your tool bag that you're using in the course of the day. Because, of course, everybody's going to have to fill out documentation. And we know that documentation isn't doing anything but increasing because of all of the fraud and other things that are trying to be prevented, and trying to make sure that patients get the best care, and for providers to be reimbursed for what they have been done. Documentation is that key element that's in there. And also, documentation is not necessarily static. Now, granted, there are some documents that do stay the same, such as your intake form. It may not change over the course of years, but it can, because it depends on what type of dynamic practice you have. And when we talk about documents, I remember this one client we had come to us, and he had it all worked out. It was really great. He had a 40-page citation of what he wanted his documentation to look like and what he wanted to do, because his particular document that he wanted, being a psychiatrist, he wanted it to be dynamic and to ask questions and to prompt certain responses from the patient on the intake. So these are the kind of things that are tools that will make either the process of bringing a patient on board easier, or noting a visit. Just like with the dermatology, we've been working with some AI responses for intake, and also with doing the live notes. So as a patient is being seen by the provider, of course, you've seen this in a lot of places, and we've had it implemented in a few of our practices now, where they can, as they're interviewing the patient, go ahead and the system write out a note for them, or after they've seen the patient, just use a few key phrases for that visit with the patient to have the system crank out a note for them. And we've been able to reduce the time that providers spend on the note generation by 80% over the last 6 months. So there are some really great tools that you can use in order to enhance the documentation feature, but you do have to have in mind what your documentation has to be for your particular state and particular practice type that you have.
So I'm glad you said that, because I think that documentation in some recent, at least topics or articles that I've read, that is still, one of the pain points that physicians do, have some concerns with. That at the end of the day, they're concerned about bring it home and having to be in pajamas and still noting and things like that. So I think that amongst the articles that I've read and some of the tools and technology that's out there to help that with the documentation. Now let's get to another pain point of clicking. I know that we've all heard this. There's so many clicks, and we go from click here to click there and whatnot. What is GSE? JSE is in terms of from your build and from things that you with your practices that you've helped with in that pain point of clicking, because I know we've all heard it. I think that all of us that are in healthcare that have been exposed to a physician practice at one point in time, or have worked or things like that, I think we've all heard about too many clicking.
Right. And unfortunately, at first, from a developer point of view, it's kind of the nature of the beast. But then we've learned to tame that beast by being able to shortcut where you're doing. And that's where we're going back now to workflow, because it's essential to know what the workflow is so that, one, we can get you from point A to point B as quickly as possible. Because when you first build a house, it's sometimes like when you first build a house and you have all these different rooms in there, and these rooms are great, but then to walk from one end of that house to the other, sometimes it becomes cumbersome because you don't want to keep making that same journey. Is there a way that I can get there faster? And those are what we look into. We had one situation where we took a feature from eClinicalWorks. And the doctor said in order to get that particular function done, he had 26 clicks to get there. We got it done in 5. Okay. So it can be done, but yes, clicking is one of those things that is very annoying. But in order to really optimize the software, we need to know what it is, or the end result that's trying to be achieved. Once we know what the end result was trying to be achieved, then we can do our level best to make sure that it can be done in 1, 3, or 5 clicks and be done with it.
That's interesting. That's pretty amazing there. We go from 26 to 5. I mean, that in itself, just to the reduction of how many, that particular example that you gave, that had to be good sounding music for the physician's ears, I'm sure, let alone just his again, the hands of the clicking and going and navigating from each field and section.
But see, that becomes a relationship and a conversation between us and the provider, because the provider knows what they're trying to do, and then they need to communicate that with us, the developers, to get them where they need to go. Because without that really tight in conversation that we had with Dan was the provider working with us on that. Mm-hmm. Without Dan's guidance, we wouldn't have gotten there. But with Dan's guidance and, again, that long dialogue, we were able to take the vision that was in his head and make it a reality. So that's why we said we build dreams.
I'm glad you said that, because, in anything, even with workflow, care team input and feedback a lot. And I mean, like, that's entirety. We're talking full house. We're talking, your front person, your the folks that room your patient, and even the clinicians. And again, depending on how you're staffed, right? You have a provider, nurse practitioner, or any APP that you may have. And then you have, your frontline staff and your back end folks that are taking care of charges and reimbursement. Having said that, I think that in the conversation that you just mentioned, I think it's important to have all your care teams at the table. to
Yeah.
be able to talk about what they do every day. And you
Hmm.
and I, as consultants, we're external to their practice. We don't live it every day. We do bring some skill sets in terms of knowledge base and so on of what we can do to help them. But it's also important to have that conversation to each and every care team, because they are touching the EMR every day. This is what, how the patient is checked in. This is how we normally do things in the practice, which we won't necessarily have, a sense of line of sight per se. We may bring some other experiences that we've had other practices that could lend itself, but ultimately it's there. It's like your own house. You know how your house functions. You know how the light gets turned on. You know how, you come in, whether you come into the front door, come into the garage, or whatever the case may be. It is your house that you live in every day.
Hmm.
So I'm glad that you mentioned that. So, okay, so back to the building pieces. We've got workflow, we've got team feedback, discussion of how that, design should look like, and thinking about the end product. We talked about some tools and some things that they can use within their practice. I think the one thing I do want to ask about scanning, because sometimes documentation scanning, while we say we're digitized, but we still have some paper. So sometimes some of that component is a bit of a last thought to some extent. Is there, what kind of thinking could we think about that in terms of scanning so that we continuously are up to date? Yes, there are some interfaces that happens, for some EMRs that are open to, being able to integrate that and come through their EMR, but we still have some paper that come through. So what would you suggest, kind of the how to stay on top of it without being, kind of like overwhelmed or snowboarded with like all the papers and whatnot?
Okay, now you really asked a difficult question on this one, because I just had this conversation 3 days ago with someone about scanning. Because scanning is, yes, going from, yes, we do have paper and we still have things that are in the physical world. And that's where we're going, is from the physical world to the electronic world. And they are two different worlds. And unfortunately, because of where we live in society now, when I say where we live, meaning the internet world that we live in, security has got to be a forefront of whatever you do. And I tell people the reason that some things are difficult, and they're difficult on purpose, is because of security. Now, there's a security risk with getting anything into the electronic world. So that's why documents, getting from paper documents or from physical records into the EHR is always going to be cumbersome, because you got to go across platforms, because you got to go from the local machine to the web server, and then to the application. And each one of them have their own hurdle and security measures to make sure that there's not a bad actor in here. Okay. So you still, for whatever you're going to do, and it doesn't really matter whichever software that you're going to use, they all do the same thing. And in basics, is that you're going to scan the document to the local machine. There is no getting around that, because that's your first stop for whatever you're scanning in, whether it be a piece of paper, an ID, or an insurance card. It's all going to the local machine first. The only one, okay, the only one that's a difference in that is when you're going from a mobile device, because a mobile
Mm,
device has the capability of streaming. Now, streaming is harder to hack than an upload, because an upload
mm,
has an intermediary where, if I'm on the mobile device, then that is the connection, and it's a one-to-one relationship. So therefore, I can stream a image from a mobile device directly to the server, where I can't do it from a desktop device, because the desktop, again, doesn't have that one-to-one relationship. It's got to hop between locations to get to the server. Don't let me know if I'm getting too technical here.
no,
So,
I mean it's interesting for me. There are some technicalities there, I will say. I think, but at the basic, what I understand is, and so let's just back it up just one bit. We
okay.
all know we still have to be regulatory, and there are some like regulatory pieces, and it's definitely compliance that we have to apply, which I think from a generality, so to speak, when we talk about these things, there has to be done. Hence, this is why when the patient agrees to send in a digital way of integration. They have to approve it. There's some approvals that need to be done, et cetera, et cetera. So I think I don't want to lose that part, that there is some regulatory and compliance.
Yes.
Now, what I understand from there's no from an actual visualizing how it all works is that, from a scanning to a piece of document into a local, you would need that scanning machine. So like
Yes.
there's there's a little bit more step, I think, in
Mm-hmm.
terms in a machine scanned physical paper.
And
Whereas,
I can't cut that out.
right. Whereas in mobile, that seems to be a direct. It's a
Yes.
direct stream through into the EMR or EHR, whichever you have.
Yes.
That so it's not, that connectivity is like straight through. You don't. There's not a one hop that you have to do over to from a machine with a physical paper over.
Mm-hmm.
So it's like it seems to me it's like a device to device. That is
Yes.
why it's kind of going through straight through. Okay. I think
Yes.
from a basic understanding of that visualization, I think is that it's not too technical in the sense that understanding how the flow of information is coming through, that there's an extra layer with a physical scanner and a physical paper versus
Yeah.
a mobile device and going into EMR because it's more of a direct stream.
Correct.
Okay, okay, I understood that part. Okay, so we addressed. Let's go back again just to make sure we got our building blocks. We
Okay.
got the workflow, and folks, I also want to, if you have any questions, please put it in the chat. But I want to also let you guys know that this is a living, breathing document. So what exists today in terms of even just workflow, just to kind of put that onion back a little bit as we're peeling it, is that it changes. Some things are going to change. And so, I wouldn't say that you would be rigid in that extent of your workflow. There's going to be some changes. And then we have to see how it goes when you go live and implement. And when you're touching it every day, what are some things that you are, experiencing that, what you didn't know today as a new practice. As an existing practice, what change that is and the changes that you've made, how is that going to affect once you go live? Some things you're going to learn as you go. So I do want to preface that, again, we're embarking on an EMR. We're putting some of these pieces into the planning and your decision of what you want to go through and which path, but knowing that once you go live and what you implement, you're going to learn some things that you didn't anticipate in some of the planning, or some things could be better. There's some things you realize, I think we could do this because this is what we've learned, from our implementation. So I don't want to be remiss and not mention that. So workflow, we have then our tools, our digital tools, and we talked about scanning, how that all comes to play. And then, then of course we're going to drop the charge, and it's going to, go through where we can get paid for reimbursement for seeing the patient or having a procedure or whatever we're doing for that day. Now, let's go into the next phase, but we are running short a little bit of time. So I want to ask Sherwin, because this is going to be part two. We are in AI conversation, and I think that that's a huge topic for a short period of time we have right now. I want to ask you, if would you consider part two, because there's no getting around it. I think AI is here. I think need to talk about what that means for our practices, what that means in our efficiency, what that means in how we see patients, et cetera, et cetera. So would there be a part two?
Oh, definitely. There needs to be a part two on this because of course, rapid changes and the prevalence of AI within the medical industry. And I'm talking about throughout all parts of the medical industry, but especially on private practices, because I've come to the conclusion for myself, just in all the research and studying that I'm doing and keeping track of what's going on, is that it would be, okay, I'm going to say it this way, not a good thing to open a private practice now without considering AI in the mix, because AI is one of those things, where it is now and where it could potentially be in the next 6 months will be that defining tool. Because when people talk about opening a private practice and the overwhelming documentation that's going on, and it's not going to slow down, it's going to keep increasing because of the regulation and regulatory things that are in place. But we know that people get burned out on doing documentation and all of this information that needs to be stored in order to just get paid. So that conversation of bringing AI in so that providers have I'm going to say, the best tools, because we're finally reaching that point that we talked about 12 years ago that an EHR was supposed to be able to do for a provider. We finally reached that point where it does actually do that, where your documentation does get scaled back so that you can go home at the end of the day, so that you can have that peace of mind knowing that all the compliancy, and that's one of the pieces that we've worked on recently, is that when the documentation is filled out, we use AI to make sure that it's compliant with all the regulatory things for that particular practice and industry and location.
Excellent. Well, we're short of time, so thank you for letting me know that we're going to have part 2. So we're going to devote our time on that in the AR conversation. But so how do we reach you? What's the best way to get in touch with you? So please let us know, and I can also add that in the chat as well.
Okay, so I'm going to give my website address. It's affordablecustomehr.com. That's affordablecustomehr.com. It's the best way to get in touch with us. We have a phone number on there and a link to a form, or you can just email addresses up there as well. But go to our website, affordablecustomehr.com.
Well, thank you, Sherwin, for this conversation. I have to say, I walked away with a bunch of, good nuggets to marinate on. Hopefully that, my audience that are in private practices, that's some things to consider. And I'm looking forward to our AI conversation. So hopefully we can get our calendars aligned and we can have that conversation again. So thank you so much for being our special guest.
You're welcome.
And I look forward to our next conversation. And so, folks, have a great day and great week. I look forward to another Back to Basics Practice Management.